We'll move on to our next presenter, Dr. Per Karlsson from the Institute of Clinical Sciences. Dr. Karlsson is presenting validation of the polar predictor in a meta-analysis of 3 randomized controlled trials of breast-conserving surgery plus or minus radiotherapy.
Okay, thank you. First I would like to thank the organizers for selecting this abstract for oral presentation. And the presentation is on behalf of all co-authors and collaborators within the SWE-BCG 91, the Princess Margaret and the Scottish Conservation Trial. And these are my disclosures. And to the outline, I will start to give a short background, going further with methods, where I will say some words about the development of the polar signature, going further to the clinical validation in this patient-level meta-analysis, and then results, and finally summary and conclusions. So it is well known that radiotherapy reduces leukorenal recurrences in all different clinical subgroups that we have seen in the EBCTCG meta-analysis. So there is a clinical need to find new predictive markers for RT benefit. There are ongoing trials out there, for instance, DEBRA, IDEA, and EXPERT. And we have, within this SWE-BCG trial, developed an RT omission signature, but that signature needs further validation in additional studies. So what about the SWE-BCG 91 study? It's an old study, and patients of the breast-conserving surgery were randomized to radiotherapy or no radiotherapy, and more than 1,100 patients were randomized. And we have collected the tissue blocks in the study, and we have collected more than 1,000 blocks. And we have performed tissue microarrays and also punched 2 cores for RNA extraction. And RNA has been isolated, and with array-based methods, we have got gene expression data. So we have gene expression data from 764 of the patients within the trial, and we have used the subset of hormone receptor positive HER2 negative patients without systemic therapy to get a pure signal for the leukorenal recurrences. And we have this subset of 597 patients, and this subset were further split in a training set and a validation set. We have used a gene set enrichment analysis in the new RT arms to identify gene sets related to leukorenal recurrences. And the most prognostic genes, and also being in the most enriched biological pathways, has been selected and further fed into an elastic net regression model using leukorenal recurrences as endpoint. And this has resulted in a final set of 16 genes, the polar score. And the scores were dichotomized into high and low, applying the pre-specified cutoff at the 25th percentile. So these are the 16 genes within the polar signature. And regarding function of these genes, gene set themes include immune response and proliferation. So going to the clinical validation of the polar signature, we have done the clinical validation in 3 different randomized RT trials: the validation part of the SWE-BCG trial, the Princess Margaret trial, and the Scottish Conservation trial. And looking at the baseline characteristics in these different trials, in the Swedish trial, we have all different age groups of the patient. In Princess Margaret, it was just patients more than 50 years of age. And in the Scottish trial, it was patients less than 70 years of age. And looking at the subtyping by IHC, it was a clear majority of luminal A-like subtypes in all these 3 different trials. And regarding adjuvant systemic therapy, we had no systemic therapy in the Swedish trial. All patients in the Canadian trial had endocrine treatment, and the majority of patients in the Scottish trial have endocrine treatment. And there was just a small proportion also having chemotherapy. So the objective of this patient-level meta-analysis in this node-negative group with hormone receptor-positive HER2-negative tumor was to examine the performance of the polar signature as a prognostic factor for leukorenal recurrences in the absence of RT and as a predictor of benefit from radiotherapy following breast-conserving surgery. So to the results, we have the 3 different sets here, and it's a very consistent result in all these 3 different sets, with a large benefit of radiotherapy in the polar high groups in all the 3 studies, and a low effect of radiotherapy, almost no effect of radiotherapy in the polar low group. Of note, there were few events in the polar low groups in both Princess Margaret and the Scottish Conservation trial. And looking at the combined result of all these 3 trials, we have a clear picture with a high effect of radiotherapy in the polar high group with a hazard ratio of 0.37 and almost no effect of radiotherapy in the polar low group with a hazard ratio of 0.92. And looking at the rates of leukorenal recurrences in the new RT arms, among polar high patients it was 20% in 10 years, and in the polar low it was just 5% in the new RT arm after 10 years. It's also clear that polar is prognostic, both in univariable and multivariable analysis, including age, tumor size, grade, and IHC subtypes in the analysis. And what about interaction? The interaction between polar score and RT was statistically significant with a p-value of 0.022, indicating the predictive capacity of this score. And in the figure to the right, you can see a huge benefit of radiotherapy in higher polar range, and in the low polar range is no or almost no benefit of radiotherapy. And looking at the distribution of the polar score by clinical pathological covariates, it's a wide range of polar score in all grade groups, and it's also a wide range of the polar score in different IHC subtypes, indicating that it's much more information in the polar score than just grade and IHC subtype. So to summarize, analysis of the polar score in 3 independent randomized RT trials show a consistent result with a minimal benefit from radiotherapy in patients with a low score. And this was confirmed in the patient-level meta-analysis combining all these 3 trials. And the continuous polar score was a significant prognostic factor in both univariate and multivariate analysis. And the test for interaction was positive, indicating the predictive ability of this score. So to conclude, to our knowledge, polar is the first genomic classifier that is not only prognostic but also predictive of radiotherapy benefit, showing a significant interaction between RT and the classifier. While patients in the high polar score benefit from radiotherapy, patients with a low score do not benefit from radiotherapy and may be candidates for RT omission. These important retrospective findings warrant further investigation, including contemporary clinical studies. And I want to thank all the patients included in these studies and the colleagues and collaborators within the SWBCG 91, Princess Margaret and Scottish Conservation RT trials, and for national funding in Sweden. Thank you.
We'll start with an online question. Please comment on how this cohort and polar stratification might correlate with Oncotype DX and the ongoing Oncotype RT trial.
The correlation, I think the ongoing trials, they may identify low-risk group with a very low benefit of radiotherapy. I think it's more information in this assay regarding the predictive ability, because it's optimized on leukorenal events primarily.
Microphone 4.
Hello, Karina Darbinyan, North Dakota. My question echoes that online question somewhat. So we now have abundance of biomarkers and getting more and more. And of those 16 genes in your assay, was there any overlap with the genes, the 16 genes in Oncotype DX? Thank you.
No overlap of genes, but Oncotype can identify low-risk groups, so maybe they can identify some proportion of patients, both of them, but I think it's more specific radiosensitivity information in this assay, so no clear overlap of the genes.
Microphone 3.
Mark Bazik, Montreal. Very nice study, thank you. First question, if I'm not mistaken, there are about 700 or more patients in the Princess Margaret cohort and several hundreds in the Scottish, yet only about 100 or so made it to the study. Can you just tell us why? And second question, how do you see migrating this to a clinically, I guess, a deliverable kind of platform? Are you thinking of, this is RT-PCR, are you thinking of nanostring, or could this be done in local pathology laboratories ultimately?
Yeah. To your first question, it's difficult to collect blocks. We succeeded quite well in Sweden, but I've heard they have very much difficulties both in Scotland and in Canada to collect the old blocks. I mean, these are old trials, so difficult to collect them. So, but yeah. And to the second trial, second question, we will perform analytical validity and transform it to qPCR in the future. I think that's the way forward. So it's a lot of work to do there before we can enter clinical practice.
Online?
Yes, we have several more online questions. Congratulations for a very nicely designed and validated genomic profile. Have you applied this to DCIS?
We haven't tried this in DCIS, but I mean, it's possible that it works. I guess that there are maybe some other genes there, but we haven't done that yet, but it's interesting for the future, definitely.
And then for those who did not receive radiation, did all those patients receive appropriate systemic therapy?
It was old trials, so in the Swedish trial it was no systemic therapy, and I guess that was good for developing the assay. We could look very purely at the locoregional signal from the genes without systemic therapy, but in the Scottish trial all had tamoxifen as endocrine therapy, and also in the Scottish trial. So it worked also in these trials. But of course, it's not the most modern systemic therapy used in these old trials, but I think it's worked relatively well.
And what are your thoughts about timeline to move into prospective trials? Do you have plans to approach the cooperative groups?
Yeah. Yes, we have plans. In Sweden and in the Scandinavian countries, we are discussing a trial with plus-minus radiotherapy in regional disease and try to use it also to take it further. But the first step for this assay in breast radiotherapy, we will do the analytical validation to make it a qPCR platform, and we will go from there, and hopefully we can start the prospective trials.
Thank you so much, Dr. Karlsson. With that, I think we'll move on to our next speaker.